last 25 years, I've had the privilege of interviewing and highlighting some truly interesting people. Everyone who is anyone, both the famous and the infamous. From presidents and their first ladies to kings and queens, movie stars and pop stars, captains of industry, heads of state, sports personalities, innovative entrepreneurs, and some pretty fascinating everyday people. Today, I'm proud to introduce you to Dr. Gwendolyn Scott, whose early passion for microbiology and helping others has led her to become one of the foremost pediatric HIV infectious disease experts in the United States. Gwen, it's a pleasure to talk to you.
Thank you.
Doc,
Pleasure to be here.
let me say, Dr. Scott, it's a pleasure to talk to you.
Thank you. It's a pleasure to be here.
So, Dr. Scott, I am just fascinated by your background. What first interested you in healthcare as a career path?
Well, I was always very curious about the human body. And when I went to college, one of the things that drew me was being a medical technician, which is basically a laboratory worker in a hospital or in a lab. I like to use my hands. I enjoyed the challenge of the learning about healthcare. And that seemed to be the perfect thing for me to do and spend my life doing.
And Dr. Scott, your expertise is very specific, pediatric infectious diseases. And since we in our country and in our world are in the midst of a global pandemic, I would imagine that you're called on a lot right now for your expertise. So why don't you define pediatric infectious disease expertise?
Well, it's a very broad topic at this point. One of the main things we do is obviously to see children with various types of infection, whether it be bacterial, viral, fungal, parasitic, and take care of those children either as an inpatient in a hospital or in the outpatient as a clinic, in the clinic. I think that there are many other things that one does as an infectious disease specialist. We do what's called antibiotic stewardship, which is teaching people how to use antibiotics. And one of the reasons for this is to help to prevent resistance to antibiotics, since we now have organisms that have many, many resistances to some of the common antibiotics that they used to be sensitive to.
So, ma'am, you described a variety of things that someone in your specialty does, but what kind of work would you do on a daily basis?
Well, it depends a little bit. I'm in academics, so in general, we would train fellows who are young faculty, who are young doctors to become infectious disease specialists. And they would generally have a 3-year fellowship with us. We would also provide mentorship for younger faculty. We would be seeing patients on a regular basis in the hospital, along with the residents and fellows. And we would also be seeing patients in the outpatient clinic. So a day can be extremely varied. Perhaps the morning in the hospital and the afternoon in the outpatient clinic, and then consultation for many of these other issues with regards to antibiotics or what to use, when to use it, etc.
We're in the middle, as I mentioned, and as everyone knows, of a global pandemic. Are there special issues that come up with the treatment of children who suffer from COVID or coronavirus?
Well, I think the major thing is, making the diagnosis. And if they are not symptomatic, they would be watched carefully. And if they did become symptomatic, it's possible that they would end up in the hospital. Children can get ill with COVID, and they should be protected the same way that we protect ourselves.
And that really does bring me to something that I know all the viewers are going to want to know. What are the tips you wish the general public would literally take to heart with regard to stopping and then spreading infectious disease?
Well, I think that the gold standard is washing your hands and washing your hands and washing your hands again. That's very, very effective in preventing spread. The other thing is, particularly with COVID, is to maintain personal distance. And with COVID also to wear masks because it is airborne. So each infectious disease is a little bit different in terms of how it's spread and what one might use or one might have to do in order to prevent its transmission.
I see that you've done a great deal of work studying the long-term effects of HIV and AIDS in children. That's God's work right there. So I would love to hear you speak a little bit about that.
Well, I became a faculty member in 1978, and in 1981, we saw our first children with what then was an unknown disease. And these were two babies. They were both less than 6 months of age. They were both very, very sick. They didn't grow well. They had diarrhea. They had other gastrointestinal disease, and they ultimately died before 1 year of age. And this was just the beginning of our seeing a number of children that had the same type of disease. And it was clear that there were also similar children being seen in New York and New Jersey and also in California. And so the initial descriptions of these children were published by New York, New Jersey, ourselves, and California. And this described what we saw in these children. And as I said, many of them were very, very ill early on and died. The interesting thing is that the rest of the family in general, the mother and the father, were not ill. And so we followed these children and had many discussions about them. The CDC had meetings with pediatricians to try to decide what these children might have. And then ultimately when the virus, the retrovirus was identified, we were able to go back and look at some of the serum specimens that had been saved on the children and found that they did have the retrovirus, which now we know as HIV. So that by 1984, we had described about 15 children with HIV, and this number just grew over time, the number of children that we saw in the hospital. So we did a lot of natural history studies to find out exactly how this was transmitted, whether the parents were infected, and how the babies would be getting infected. There was no treatment, but people tend to be very courageous despite the fact that there is a lot of unfortunate illness in their family. And I think that we learned from them as much as they learned from us, even though there was not much that we could do for the children other than supportive care.
Once you know enough about the disease and you know how to treat it, in order for that treatment to be effective, you have to make sure whatever behaviors are going on in the house, in the environment, are not going to put that patient in risk or at risk of still having a death sentence when it's unnecessary at this time.
Right, and that required a lot of education because there were groups that did not feel that AZT was an appropriate drug to give to children or pregnant women or even adults. And there was a lot of negative advertisement about AZT, but that was the only thing that was available at the time. I won't say it wasn't without side effects, but it was the only drug available. Then as more drugs became available, I think that a lot of education was necessary to understand how these drugs worked, why you had to take them every day, maybe once or twice a day, and, hope for the future that there would be other drugs that would be developed that would help to maintain health in the infected patient.
And I noticed as a journalist and someone who worked in the media that the even the communications, the marketing became more about living with HIV rather than dying from. Because
Yes,
with your education and the research that you and your colleagues were doing, that would make a person actually have something to live for. If they,
absolutely.
if they
Yes.
could just do, what the scientists are suggesting.
Can I tell you one more thing that we did that I think was our greatest glory?
Absolutely. I was about to ask you how what milestone, but let's do it right
Well,
now.
the milestone, I think, was first of all, treating children with AZT. But the second great milestone was giving zidovudine to pregnant women to prevent HIV transmission to their infants.
Mm-hmm.
And so early on in the epidemic in the late 1980s, we devised a study, and by we I mean a lot of different people from different institutions, devised a study to treat pregnant women with AZT and then to give their babies AZT for 6 weeks compared to a placebo to see if they could reduce the transmission of HIV. And the transmission was reduced significantly from about 24% to 8%. So that was a very, very successful trial. And now with stronger drugs and the ability to use shorter courses, we haven't had a transmission of mother to child through pregnancy at our hospital for, I believe it's about 3 years.
That's fantastic. That is
Yeah.
fantastic. And Dr. Scott, finally, what is the one thing you'd like the viewer of this video feature to walk away with?
Well, I think that, first of all, being a physician has been a wonderful profession. It allows you to help people. It allows you to educate others. It's a lifetime of learning, and it's very exciting. I enjoy puzzles and mysteries, and so a lot of times you don't exactly know what a patient has, but you have the tools, hopefully, to sort that out and to be able to help the patient. So I think that we also know that you don't treat the disease, you treat the patient, and that a lot of times we learn much more from our patients than they perhaps learn from us.
Well, I also say it's a beautiful thing when a career and a passion can come together, and very clearly, you are Exhibit A in that regard. Thank you so very much for your contributions, Dr. Scott. It's been a pleasure to have a conversation with you today.
Thank you very much.